And good morning, everyone. This is Joe Basha. Welcome to PerfWeb 101, day 3. Huh? Yeah, day 3. No, day 2. Day 2. I'm not sure. I don't know where we're at here. Okay, I'm not sure what we're doing. Anyway, I'm your host, Joe Basha. Welcome to PerfWeb. I've got several things to talk about. We're probably going to take a little longer in opening remarks because I got some things to kind of go over. But let's get through the basic housekeeping notes like we always do. So if you wish to contact us, you can reach out to us at contact@perfusioneducation.com. Feel free to call that number at any time. Email that, and we generally respond within a day or so at the very latest. Sometimes if I'm sitting there looking at my computer and it goes off and I see the email, I'll respond to it then. So very happy to receive emails at that location and ask anything you'd like, recommend anything you'd like, comment on anything you like. But of course, you all know my preference. My preference is for you to pick up the phone and call 832-239-5358. It's right there. You see it at the bottom. Call that number. Be live on the air. Because today we're going to have somebody really special on this program. So you're going to want to do that. We have the Chiron at the bottom down there. That's the crawler, whatever you want to call it. That will be there intermittently throughout the day during the program. So you can look at whatever that is there and do that. But for those of you that may be driving, 832-239-5358. That's that call-in number. Now, you know about our app. So we're going to skip that because I'm going to show some demonstrations on that app. So let's just go right forward to the podcasts. You can go to your favorite podcast streaming software. Doesn't matter what it is. Type in PerfWeb podcast series. And there it is, and you can listen to all of these programs at your leisure. Of course, you don't get the benefits of the slides. I think it's better to watch it on the YouTubes or the FaceTimes or the X's or whatever, XY, whatever it is, and go from there. I guess you really can't call it. You can't call it an XY because that would be too gender specific. We'll say it has.
Can't call it 2 X's either, then.
No, you can't call it 2 X's either. That's Dos Equis. That's a beer. That's a beer. That's a good beer.
See?
But I guess it could have, what's that syndrome?
Klinefelter's XXY.
Klinefelter's, yeah. It could have Klinefelter's, yeah. That's what it is, XXY. Klinefelter's, that's what we've got here. But that's the podcast there. So, and of course, I'm joined today again with my good friend, and now officially got his card today, licensed cardiovascular perfusionist in the state of Texas.
Thank you.
And I cannot wait for him to finish this program today because we are going to actually put him in an operating room and he's going to actually do a case today.
Oh, man.
So, and I'm just going to stand there and watch you.
All right.
Should I pray?
No.
No, good.
Maybe the patient should pray.
Maybe not.
No,
I don't believe that. Okay. So I do want to talk a little bit about our app. Okay. So I'm gonna start this off by listen, I'm gonna close that completely out. Just leave that part up, and I'm gonna reopen the app. Okay, from the very beginning. So if you look on my screen here, you see this icon down. I don't know if you can see it or not. Different view. No, that's it right there. I can see it. There, you see it right there. You see that. Oh, no, you just had it. Okay, but I'm going to hit it right here, down here, the bottom right. Yeah, right there.
Right
that
next
medical.
to the Safari icon.
That's it, right
Between
there.
Safari
I
and PowerPoint.
I can draw on it. Wait,
Yeah, you
wait,
can.
wait. I'm going to do this. I want to have some fun today, okay? I'm sorry. I'm in the. I got to go to Telestrator? Never mind. Okay, I'm just going to open it. You tap that thing. You saw what it looked like. There's the little logo, and it brings up our app. Okay. First thing you're going to get is that little advertisement. It only lasts for 3 seconds, but you can X out of it if you want. But let's give you an example. Perfusion. Okay, Now open it up. Your first thing in the morning, Perfusion Quick Calcs. You have a female patient. The patient is 65 years old. She just made Medicare, I guess eligibility would have been sooner, but she's Medicare eligible. She's, not a big lady, but she's not too small either. She's kind of in between, and she's maybe, you know, she's a little dry, but her crit right now is reading 32, but you're like, she looks dry, but nevertheless, that's what you got. Her height is 167 centimeters. Her weight is 72 kilograms. Your pump prime is going to be, let's say 13, let's say it's 1,000 after you're done wrapping, even though I don't believe in wrapping.
He doesn't.
Anesthesia, she was dry. They needed to give some volume, so they gave 1,500. Probably could use more than that. She's on a little background Norepi just to keep her pressure up. Pre-pump urine is not in zero, but it's not a whole lot. Give you 120 cc's, and we'll just use 3 per kilo as your heparin dose. Hit calculate, and here's what you get. You get BSA, BMI, estimated blood volume, red cell volume, heparin dose. Estimated pump on crit's going to be 21. We both know it's going to be lower than that. What your protamine dose would be, even though I don't think that was a necessary element, but we put it in there. And then we have our flows calculated from 1.6 to 5.4. This is just a real quick, easy, down and dirty way to figure out what's going to happen. Now, let's just say you wanted to say, okay, I've got 1,000 of prime, but I'm going to have 1,000 of Del Nido right off Jump Street. So I'm just going to make that 2,000.
Yep.
And let's get a better representation. And what's nice about this is you go back and make those changes, recalculate, and now it's going to give you a new estimated crit on pump of 18.5, 18 and a half.
Oh, yeah.
So it's a very quick way of being able to sort of analyze what's going on. And you can change this at any point in time until you finally do check your lab to see what that's going to be. But it's very helpful, and you can include in it what your prime, if you're going to add blood to the prime and you know the red cell volume of your blood, which you should, then you can factor that into this as well, and makes it a whole lot easier. And then if you want to go to, you know, something like, let's say COP. We've talked about COP so much. We'll say the globulin is 2, your albumin is 4, calculate. Your COP is 24.8, well within normal range.
Great, right
but
about
if you
it.
sit there and you have what I typically see, 1.1 and
Like 3.0.
yeah, 3.0. I was going to make it 2.9.
That works too.
We'll make it 3.1. I'm going to be generous.
Okay.
Now look at that. You're 18 point. You're 18 and a half. So you're
That's
below.
yeah. So that's gonna
This
shift
right
it the other
here,
way.
when you see this. This, oh, it won't draw. This will be indicative that 18, and it's going to get worse than that. Of course, it always does. You're going to start third spacing volume.
Yep.
So you're hypooncotic,
Yep.
and so you can tell that right away. So if we want to add some albumin, or you check the albumin, you're probably not going to do much for the globulin, but you can change this and get a different number. Other things you can do, for example, is estimated blood. This is a really neat one. I'll tell you one that I think is really kind of neat. What? No, I'm not doing anything.
Can you try this one?
I'm minding my own business, doing absolutely nothing wrong. Here.
Absolutely nothing wrong. Says every person that's ever done something
Yanking.
wrong.
I mean, Magic is sitting here yanking on the wire, and you wonder why they break. Is that better? Yeah. Okay. Well, there was, I don't know what's wrong with it. Okay. All right, so there's that. Now, in addition to that, you have hemodynamics. So if you, and a lot of it's in there. So some of this is redundant in different things, as you can see, because you have COP here too.
You got
but
SVR in
calculate
there.
your
That's-
SVR.
Yeah, that's nice.
I don't know why it's not working. Magic. Oh, there it is. SVR, mean arterial is, let's say you're trying to come off bypass. Mean 65. CVP is about 2. Cardiac output, you're on pump and you're flowing, let's say 4.5. Your SVR is 1100. You look good. That's a pretty decent SVR. I like to be above 1,000 to 1,200 to come off.
Yeah.
So that would be really nice. But if you were sitting
Yeah, you don't
here-
want it to be more towards like 14 because then it's just too
Correct.
much resistance to push against.
Oh, that's
you're-
oh, I see what you're
This
saying.
one
Okay,
you can
so
write
use
on.
this one. I can write on it.
Yeah.
That's why. Okay, so anyway, but it gives you that information. And then you come over here, you want to see what your coronary perfusion pressure is. take your diastolic pressure, which is we're going to give it 60. And we're going to say your wedge pressure. You know, if you had a PA, of course, you'd have to have a PA. You'd be able to get a wedge pressure out of it. But if you could, it's 12. And then you can look at your coronary perfusion pressure being 48, which is too low. Okay, and that's going to mean that you're not getting the coronary perfusion that you want, and you need to correct that.
Right.
And these are just really kind of neat things that you can come up with. In ECMO, you have your DO2, if you want to calculate DO2, or more, I guess, commonly is DO2I, but you can do this on pump as well, right? It's in the perfusion section.
Yeah, that's
we'll
great.
give you a crit, hemoglobin, let's say, of 7.3. You're like, I don't want to transfuse. I really don't want to transfuse. 100% PO2 is 400. Cardiac output you're on pump is 4.4, and your BSA is 2.1, and you're at a DO2 of 234. Nowhere near
where you need to be.
Where you really want to be.
Can
right?
you try a 5.2?
I drew on this, but it didn't translate over there. No, but that's okay. This is fine.
Can you
I don't need all this. Take that away from me.
Can you try a higher flow? Let's see what happens.
Yes, I can do that.
Let's see
so
if we can fix
oh,
it
I need.
with flow.
Yeah, that pen's there. So let's fix it. Let's try to fix it. Let's go to 5 liters.
Yeah, let's try that.
Okay. Still under 280, and I
Yeah.
think 300 is really the number that you need.
Yeah, 280 is
So-
like the bare minimum.
So let's say you've got a whole bunch of volume in your reservoir.
Hemoconcentrate.
Should I add a unit of, say there's a liter in my reservoir. Should I remove 500 with ultrafiltrate and run at a level of 500? Or should I give a unit of packed cells and give myself 1,250 in the reservoir? Patient's not peeing. We're kind of 2/3 of the way through the bypass run. We're going to be wanting to come off bypass pretty soon. So,
I mean,
what do you do? So let's move this up to 8. Not even a lot.
Is 500 going to be enough to come off? I don't think it will.
I don't-
You'll be able to fill the heart.
I'm
but
going to
that's
see.
about it.
288, still under 300, but
Yep.
it's getting closer.
It's getting closer.
It's getting closer. So so maybe if you had 1,500 in your reservoir,
Okay.
you took out
500.
800.
Okay, yeah.
You know, then
that should be good to come
It
off.
should be all right.
'Cause the
So if you
BSA 's
could
not
get
that high.
if you could get your crit to 8.5, I think you're going to be over 300. You are.
Yeah.
So there you go, and that's where you want to be. So I would say 280 is really the number.
Right.
But, you know, if you can't flow 5 and you have to flow 4, and you're going to need a hemoglobin about 9.
Right.
And even that's not enough.
No.
So you see a liter of flow with only 0.5 change in my hemoglobin up, still not enough.
Yeah, it's not enough.
And
Correct.
that's not a bad hemoglobin for being on bypass, but you can
No.
see how incredibly sensitive DO2I can be. But it gives you that really quick access to information. You can measure your O2 transfer rate for your oxygenator. You can measure your oxygen extraction rate. This is a very good formula to have to look at what your patient is actually extracting.
right.
If it's extracting more than 25%, well, you're underflowing.
Yeah.
Right?
Right.
You want it to be you want your extraction rate to be somewhere between 20 and 25%.
Right. That way
is
your
optimal.
SVO2 is around 75 then.
Correct. That's what gives you that number.
Right.
That's where that
Right.
number comes from, right?
Right.
And then you have clinical calculators. You can do drug half-life. You can do how much O2 is remaining in your E-cylinder. You can calculate BSA, BMI independently. You can calculate drug absorption. You can calculate so many different things. Allowable blood loss. This is great for anesthesia. Let me give you an example. Your weight is 82 kilos. Your initial hematocrit is 35. The lowest desired hematocrit you want is going to be 28. How much blood can you lose and replace with non-heme beforehand? Click that. You can lose 1.2 liters of volume. His estimated volume is 6.1 liters. You can lose 1,200 of blood replaced with asanguineous fluid,
Right.
and your hematocrit will be 28.
Oh, that's really helpful.
That gives you an allowable blood loss to achieve the
Right.
hemoglobin you want.
Right. That's nice.
It's a very good formula.
Yeah,
It's
that's a
very
really
nice.
nice
It's
formula.
quick, and it's these are all. If you go here, not that. If you go, for example, allowable blood loss, and click here on the eye anywhere, you're going to get information on the
Oh, yeah.
calculations. These calculations, by the way, are every calculation in our app has been validated by either a clinical, a doctor of clinical pharmacology, or has been validated by a gold standard resource that we used the formula from. So all of these have been validated as accurate and functional. So everything's been tested and tested and tested. The other thing that is really cool about this that I don't think people really give enough credence to, which I spent a lot of extra money on, and I thought it was really important to do. I'm going to go to this, and if you look right here, you click on, where is it? Perfusion. Here. Okay, no, it's not there. Where is the, maybe it is in here. Let me see.
What are you looking for?
Where's the one with the kilopascals? How do we change that? How do we change that, Magic? Oh, you don't know? Okay. I guess I can't show it to you for some reason. I may be making a mistake here, and I apologize if I am. No, this is it. This is it. Yes. Here you go. So for our European partners, if they have a hemoglobin of 8, SAT of 100, but they run their thing in kilopascals. So what is a PO2? How many kilopascals is a PO2
no
of
idea.
400? Well, you can calculate that too.
Really?
But yes, we can calculate that too. I don't know it off the top of my head, but I'll just say it's 200.
Okay.
For the sake of the argument, because I don't know.
Right.
And BSA 2.
Okay.
And calculate. So there you go. With if it was 200 kilopascals.
Yeah, oh, then it would be 3.
Look, it came way up.
Yeah. Oh, wow.
Yeah.
That's a
So
lot
it
of
just
oxygen.
depends. But the point I'm trying to make is that we have this in various, you can make
Units.
these changes, right?
Right, you got different units.
So we have it so that our European partners or our Asiatic partners, depending on who uses the KPA versus the scale that we use, then they're more than, they can do that. So it's good across the continent or across the globe,
That's
if
good.
you will. Okay, there, that takes care of that. Thank you so very much. Okay, we're gonna ready to bring Matt in. All right, so I think we're ready. Is there anything I forgot?
No, I think you got it.
Okay, good. Thank you all for your patience with that, my little demonstration there. I'm trying to sell 1 million of these things. It's $2.99. That would give me my portion of that 2.9 million, which is enough for me to move and go retire. So anybody that wants to get rid of me, just buy 1 million. Actually, you only have 999,999 to go because I bought the first one.
There you
But
go.
it is available. Hopefully, Matt will buy it. All right.
I bought one, so
You did? You good? You good?
You're
Good?
2 down.
I'm 2 down.
Yeah.
I'm 2 down now.
You're 2 down.
So now I need to go to. Okay, so let's bring Matt Warhoover up. Matt, my good friend Matt, how are you? I consider this today to be a real opportunity for people to hear from somebody who I regard as certainly an expert, a true expert in NRP. I am certainly not. And all of what you're going to be discussing today has to do with your experience at Vanderbilt and the Vanderbilt NRP program, and also I believe Vanderbilt again had the highest heart transplants number in the world. So you're now again the world leader in heart transplant procedures, certainly nationally. I don't know if it is the world, but it certainly is nationally. And maybe you could talk a little bit about that. But I know you guys have some funny roles out there, Matt, and I want to make sure that I introduce you right. You know, you are on our faculty. You can look Matt's bio up, but you're not the chief of perfusion there, but you're something, and in that leadership role, but you have it all divided up, so I can't figure it out. Can you help me?
Yeah, we have two sides of the Vanderbilt house. We have the children's side and the adult side. I'm the chief of the adult side.
Adult side, okay. Is there a chief of the whole section that covers both?
No.
Okay, so you and somebody else works together, so you're chief. Now, on a sour note, and if you don't mind me bringing this up, I just feel like I have to shift gears a little bit because so much has changed in our industry. But you all decided at some point that you were not going to continue with the school. So the Vanderbilt Perfusion School, has that officially just come to an end, or are you retooling it, so to speak, to bring it back?
As of this moment right now, we have one final class that'll graduate in May, and then we are going to close our doors, and we're going to see what the future brings. But that's really all I can say right now. We're definitely going to be a clinical site for some perfusion schools, and so that's always promising because I think the clinical experience at Vanderbilt is second to none. And so I think if there's anything that is done with perfusion, you can find it here, whether it's HIPEX or left heart bypass, liver bypass, ECMO transports.
I know. I mean, you guys had one of the most incredible training programs ever, and I don't know, man. It's going to be hard to. I don't know. It's going to be hard to replace it. I'm a little, but I'm curious what you think, where you think this industry is going. What do you really think we're looking at here? Because a lot of schools have opened up.
Yeah, I think I think there's something to be said about OJT. I think because you kind of did the years ago you did the self recognizing who quote could be a good pump tech.
I'm OJT.
Yeah, and so if you revert back to that, it was the round peg trying to find the round hole, and so you had surgeons and perfusionists that were looking for their colleagues or looking for people that they wanted to work with, and you handpicked them and then you trained them up. And now with the gluttony of jobs, schools opened up, and I feel that the niche of perfusion, and people recognized what kind of lucrative income came along with this profession. But what I don't think they realize is that the work-life balance commitment that came along with it. And so, just in our experience at Vanderbilt, we've seen one or two clinicians that leave here as graduates within the first 5 years. Definitely within the first 10 years, they're out of perfusion and they're in their ancillary role. I'd say almost 20% of our graduates are probably in some sort of an ancillary role.
Really?
Whether it become, they work for industry, or not even industry, the Medtronics, the Levonovas, the Trumos, not the major players, even, when it comes to heart-lung machines, Spectrum, it's even the ancillary products, whether it be Datascope or it'll be Abbott, Transmedics, any one-off that really doesn't have, I wouldn't say has to do directly with perfusion care, but is definitely in our wheelhouse. Hemonetics, all anything that you can think of, whether it has to do with ACT machines, cell savers, the hemonetics, it escapes me. The clot product that they determined.
Angiovac.
No. They put the imaging on there of what's your platelet, the R value, and all that.
TEG.
The TEG machine. Yes, I think anything that has technically that's kind of in our space they really recruit perfusionists pretty hard because I think for two reasons. One, they're pretty knowledgeable across the board, across the industry. They have to be, they have to know a little bit of everything. But on the same token, they know what kind of, dedication it took to get there. And so I think it's an easier avenue for them to kind of, attract an off ramp for people that are looking for it.
Yeah.
And unfortunately, I think that also has hurt our education. Getting full circle back to what you said, Joe, is that I think our education, there's people that like to teach. There's educators out there, but with the affordability of what an educator may make versus what a perfusionist makes, what a perfusionist that turns the industry, what you make. There's a lot of different options, and when it comes to financial satisfaction, I think the perfusion education is probably at the bottom of the barrel when it comes to the more or less the financial aspect of that.
You are so correct. Which
leads us to have people getting cherry picked from education that truly do like to do it, but for financial concerns, they can't afford to do it. And so
unless they're in a position that they can afford that and they want to spend more time at home and they need a more consistent, but then that's not really the person the industry wants.
That's correct. So, educators like to educate. And so, in the event that, you're getting into education for a different reason, that's a problem. But, people are leaving education because of, I believe, the affordability of what the opportunity at other places and other avenues of our industry.
Well, I mean, you brought up several really important points. And first of all, you're right about education. And the reason why that is the case in perfusion is there's only 4,800 of us. So that's your market share. Your market share is really low. So you can't be in this. If this is what I had to do to earn a living, we'd be poor because it is only for my clinical practice that I can afford to provide this out. Right. And so everybody that is involved in this kind of game is doing it as a understandable loss leader. You have to want to do this to do it because it doesn't bring you any financial reward. It only brings you financial pain. But that's okay. That's all right. That's what I'm here for. I'm going to go do a case today after the program so that I can help to support my own habit here of enjoying doing this.
There you go. Got to offset it.
There's a fella that's online. His name is Akash. And Akash, I believe you're here. I hope you are. If you are, please let us know. And if you don't mind, if you would put on the chat, Akash, where you're from. You have a rather unusual avatar. And so we'd like to know, if you could, tell us where you're from and what you do and all of that kind of stuff. Would be very helpful. But you certainly seem to know what you're talking about from yesterday. And what he was asking, Matt, you may not be able to answer it, but we're going to try to get it answered for him, is which solution do you think is better for organ preservation? The HTK, and I'm assuming because we were really only talking about the heart, so I don't want to get into liver and kidneys, and because there's so many different organs with so many different formulas or whatever. Maybe there isn't. You can correct me. But which solution do you think is best for flushing, preserving the organ after explant for cold storage to be sent on someplace else?
Yeah.
Well, he
was asking specifically about HTK versus University of Wisconsin, comparing those two.
Yeah, and I don't know the direct comparison of all that. What I will say is that there's three major solutions out there. There's the Del Nido solution, is what we use at Vanderbilt. There's the UW solution, which he's speaking of, and then there's the custodial or HTK solution. So all three of those are preservation flushes for cardiac. I don't know exactly which is better. I think it's based on where your program's leader, whether it be whoever's leading the transplant service line, where they trained. But there are papers out there. I think one just came out of March of last year. I believe it was in the European Journal of Cardiothoracic Surgery, where they studied custodial versus Del Nido versus a modified Del Nido solution. And it's, the overall, patient stay was, about a half a day for Del Nido patients versus the custodial patients. But the enzymes markers that, create the more or less the kinase markers were higher in the custodial on post-op day 1 and post-op day 2 than it was in the Del Nido. So I think there's a mixed signal. I don't think there's one out there that's better than the other. But what I will say is that we have seen in our experience of using Del Nido, and it's depending on the length of time of travel versus when you get the longer your ischemic time, there's a sweet spot in there that it seems that the heart really comes back vigorously versus if we've got a short run, whether it be across town or maybe even, just a local 20-minute flight. If you're under a 2-hour cross clamp or a 2-hour ischemic time using Del Nido, it takes a little bit for the heart to wake back up. And so, I don't know if that's necessarily a good thing or a bad thing. I personally think that, as long as it comes back, it's fine. But I think it does have it takes a little bit of time to wake up, if you will, and flush and get all the electrolytes back and polarization right with our solution. But, we travel, we travel to Seattle, which is, almost a 5-hour flight. And we just do regular flush and go. And so
so you're saying that you guys well exceed the 4-hour mark?
We push 7.5 hours on cross clamp on ischemic time.
Are you kidding me?
Yeah, that's
No, I mean regularly.
Is that common? Because my understanding was after 4 hours, you're just really like there are people who have rejected the organ.
Yeah, no, and that's relatively true. I think that 4 hours has always been a benchmark across our industry, but we continue to push the envelope, and we're doing some other things. I actually think it has a little bit to do more, and there's a lot more studies on this, as you guys probably have read about. It's more about the temperature control of the organ.
I talked about Paragonics yesterday, and I thought that device was really cool.
Yeah, and so in my slides, I'll touch on that a little bit, but they're starting to find out that the industry it's more about in the temperature transport of it. Where you have these Sherpa packs or Paragonics, or you have a 10-degree cooler. To be quite honest, those coolers can be very expensive. Well, right. You can buy one on Amazon for $4.99 now, and that's what a lot of people are using. They're using the temperature controlled with the auto regulation. The condenser kicks on and off and keeps it in a 10-degree state.
Wow.
And it seems to be 10 degrees is the optimal. For years, we just cut the heart out, put it in a bag of slush ice, wrapped it up, put the ice on the outside of it, put it in a bucket, and we're in with it. And so, I think that mindset is where that 4-hour mindset came from too. I think we're evolving. And so, I think people got away with 4 hours because that was the way we preserve things. We're changing the way we preserve things. And so I think we're able to push the limits of what our ischemic times are. And I'm not saying I know, because that's what we're doing.
That is really impressive. Well, look, I know you have a lot to talk about with your thing. Thank you so much for allowing us to have this conversation before your presentation. I know you're incredibly busy, so your generosity, your time is really appreciated. Let me let you move on with your actual presentation, and then we'll pick up on some more questions after from the audience that I'm going to be getting.
Okay. David, are you able to see it? There are. So this is a talk about Vanderbilt's experience of DCD and heart transplantation, the case for more or less NRP. This is all Vanderbilt University Medical Center data. I don't have any financial disclosures, but as you can see here, you know, the numbers don't lie. So we started DCD in 2020. We were already a fairly robust program, and the idea. Oh, did I stop sharing?
No, you're good.
Okay, perfect.
We're good.
Okay. The idea that, you know, we had almost a 30% increase from 2019 to 2020 by bringing NRP into the mix. And you can see there was a transitioning period we were trying to figure out what the best way to evolve our program. And you know, the introduction of OCS was also about that same time, 2019, 2020. And then there's a slide later on, and you'll see how the progression of how we have multiple tools in our tool bag for organ preservation and acquisition of hearts so we can transplant. You know, we're the world's largest individual single provider of heart transplants in the world. And so, and I think we've probably been top two the last 5 years. And we're on pace. I think we just did our 54th or 55th heart this morning, year to date. So we're already on pace to actually beat our record from last year.
It's amazing. It's amazing numbers, Matt.
And so I moved on. I'm a little bit, want to make sure that I'm doing this right. Are we good there? Moved on?
Yep.
So yeah, so our
changed
glossary
slides.
of terms is essentially
Oh wait. Oh, you need to. Yeah, you need to share your
Hold on.
slides. Yeah, go
yeah, I'll
to.
share the slide. Yep,
Yeah. Not from the beginning.
got it. Here we go.
There you go.
There
Is
you
this
go.
better?
Yep.
Yeah,
let's see.
Perfect. So the glossary of terms, just so we're clear, we have donation after brain death, that's DBDs. Donation after circulatory death, that's DCDs. And of those, both of those type of donors, you know, can go on any transport system, organ, you know, the OCS, the Paragonics, soon to be Organox, the ex vivo. All those things are either FDA approved or soon to be FDA approved. But the DCD cohort of patients and donors, if they progress, is where we've kind of determined that normothermic regional perfusion, essentially recovering the organ in situ with extracorporeal support, is kind of where we feel we have a level of expertise and where we find that we have the most bang for our buck and the benefit of allowing that kind of modality and that therapy in this cohort of patients. The pros to it, it's pros to NRP is there's high quality organs that otherwise, you know, would be discarded or wouldn't be considered or, you know, go to the morgue. The cons, that there is a warm ischemic period. There's unknown risk of PGD. With the long-term risks are unknown. We do have a benchmark study going on. There's a couple papers out that after year one, they're the same, if not better. After year two, they're the same, not better. And we're still continuing to see what the long-term, what this looks like long-term. This is pretty new technology to where we were stratifying the data. To be fair, the first heart transplant ever was an NRP. And what it was a patient that, that actually died in one room, and they used the heart from that patient to another patient in heart failure. And so essentially that the first heart transplant was an NRP heart. I think there's some technical challenges, especially on the initial learning curve of this. Most people aren't used to cannulating a flaccid aorta. There's the insult of death, and trying to turn around the labs and trying to get a good global perfusion technique, and it's thinking outside the box. It's not your typical you're not your typical CBP run. And then there's staffing considerations. You send 2 people out to go procure a heart. You have to have 1 person back starting the case, and then you have to have 1 person available for any other case that would come up that's just on call. So when you do a DCD heart, we have no less than 4 people involved on our perfusion team that are actively have a role in that. Conventional DCD recovery, there is a high risk for warm ischemia and non-recovery. So you have to let the patient pass. There's usually a 5-minute standoff. Then you have to get into the chest, get on NRP, and then be able to resuscitate it. And all that time, the heart is distended once the patient passes, because it's not beating anymore. And it's just a vessel and a reservoir. And so it's going to hold the volume and continue to enlarge in the chest. And then when you open the chest, even the pericardial sac that usually holds it together, once that pericardial sac is open, the heart even expands even more. And so there's an increase of organ injury during the recovery, whether it's just from anatomical, what we do trying to get to the heart, just normal progression of death, or you've got a rapid surgical recovery. I mean, you're cannulating a flaccid aorta, you're cannulating a right atrium and trying to get things on. And many times the anatomy is not exactly what you see. You could have a pneumo, you could have a large where everything's shifted over, because you don't know what's going on with these patients a lot, especially towards the end. And then if you add one more layer of it, if you're going to take heart and lungs, or you're going to take heart, lungs, liver, kidneys, you have multiple teams trying to maximize their time, minimize, overstepping their own boundaries into someone else, but they don't want to, sacrifice their own organ for someone else's. And so the reality is there's a lot of teamwork. There's a lot of hand in glove type movement that goes on. The lungs want to be reintubated. Well, that means that someone has to be working up by the mouth of the patient. And, that's right by where a surgeon's left arm is if they're standing on the patient's right, to try to get a sternotomy and try to get cannulation. And so there's a lot of moving parts that take place. And so you really need a protocolized, organized, orchestrated event to say who's going to prep, who's going to extubate, standoff. That's just for the patient when they expire. The reverse happens as well as soon as the patient expires. You have to get the suctions hooked up. You have to make sure that people are in the right places, they're doing the right things at the right times, and coordinating with all teams. An in situ reanimation of cardiac, of more or less the heart, was not possible until TransMedics device came on the market. And they had great success in Europe and Australia prior to the trials in the US. And they continue to have great success today. And, they were the forerunner, they were kind of the people that blazed the trail for, these other commercially or soon to becoming commercially available products, whether it be Organox, Ex Vivo, Paragonix. And there's a handful of other ones that are, coming down the pipe as well. And so, this is just one more avenue. I think there's a space in the transplant world, regardless of what organ it is. All these devices, especially at a large institution, I think you have to have in your tool belt, because it matters where you're going, what the local rules are to the hospital that you're procuring from, distance. Also, what is the quality of the organ? And so, there's all these questions that, you have to ask yourself as a surgeon, and what are the real risks and the obstacles about accepting an organ, and what device, what modality, what information that you get by using these devices, and each of these devices preserve in a different way for transport. And so you kind of have to think about all those questions and kind of handpick what is the best device to safely and give yourself the best chance for a successful transplant. And so this is what NRP looks like in the field. It doesn't look much different than what we would on normal bypass run. You've got a venous cannula, you've got an aortic cannula, you've got a root needle, and you've got a vent, and you've got suckers. And so this is, if you would have taken this picture 10 years ago, no one would have thought this was an NRP circuit. They would have thought this is just open heart. And so it's not that different from a surgical standpoint, other than the one clamp that you see that's coming right at you. There's two clamps, and those are clamping the head vessels. That's the only thing in these pictures that would be different than a regular heart surgery. And so we, rapidly cannulate, reperfuse all the organs. As I talked about, those two clamps have the exclusion of the cerebral circulation. We try to use, assessment of all organs in conventional recovery. And like I said, it is applicable to all organs, even the abdominal organs. And, that is actually blown up. But we've started to do abdominal DCD at Vanderbilt starting last September. And so that's starting to grow in volume here as well. And then our timeline, I know this is probably a tight slide, but the timeline of the DCD events, it's heparin, usually a 3-minute wait period to let that heparin circulate, just like we do for bypass. There's the initial withdrawal, which is extubation and turning off all the drips and administering the comfort medications. There's an agonal phase that is being utilized in some centers. We don't use an agonal phase anymore. The SAT we don't even look at, because, as you know, the order of what things do is when your body starts to shut down and death is ensuing, is the very first organ system that gets shut down is your skin and your peripheral. And then it's the gut, and it works backwards all the way until you have cardiac death. And so we're not using SpO2, but this is a general rule of what a lot of centers are using. These are kind of based off the Transmedics, their protocol that they loaded with the FDA, and then your systolic blood pressure is less than 50. Typically, once the systolic blood pressure is less than 50, it's very hard for the body to turn themselves back around without a direct intervention. And so, although we don't look and calculate the time on that, there's a lot of centers that do when it comes to abdominal organs. There's the agonal phase, which we just talked about, and really at that less than 50, that's when we're considering functional warm ischemia. So you've got the agonal period, you've got the declaration of death plus the 5-minute standoff, and then you've got the chest entry until you get back on a perfusion circuit for NRP. And so those 3 phases make up your functional warm ischemic time. And then once we get on, and of course we verify just like in regular cardiac surgery, we repeat orders back from the cannulating operator and go on pump. We just don't say go on pump, we confirm head vessels clamp, they come back, head vessels clamp, going on pump. And so there's one little wrinkle of a step when it comes to NRP, and that's just to confirm that we've got everybody's on the same page, even in the organized chaos of cannulating after death, that we've got the head vessels clamp before we go on. Then there's your reanimation period. We get an ABG generally in the first 10 minutes, and then every 15 minutes following. In the cardiac space, we're looking to correct the blood gas. We're looking to have normal sinus rhythm, looking at a good rate of normal sinus rhythm. and then we're looking at functional status. And so after about 45 minutes, we will load the heart just like we would coming off pump, and we would monitor what the pressure is the heart's generating and the eyeball test. And I'll talk a little bit more about that in a moment. And then finally, we do the perfusion cross clamp, the perfusion of the cardioplegia solution, the preservation solution, and then the donor cardiectomy. And that's when it starts to cold ischemic time. Your cold ischemic time is literally from flush until the cross clamp comes off back in the recipient. And then implant begins, that's also cold ischemic, part of the cold ischemic time. And then we have the allograft reperfusion and the termination of your cardiopulmonary bypass. Hopefully, if not, you convert to ECMO and you buy a couple days, and then they come back off a couple days later. This is our setup, our table setup on the left. This is our mobile NRP pump on the right. As you can see, we just converted an old ECMO pump into that. It's nothing fancy. We watch, like I talked about, we watch the hemodynamics and EKG. We're doing lab work to make sure all our labs come back correctly. And then we do the 45-minute eyeball test. And that's a video that gets sent back to the implanting surgeon. And that gives us the last bit of information that he can make a decision whether to accept or not to accept. In your ex situ assessment, like a transmedics, you're getting coronary flow, you're getting pressure, and you're getting lactates. And so although, they're similar assessments, they're very, very different. I will say that the downside of the ex situ, like a transmedics, is you don't ever really get to properly load the heart to see what it can do as far as pumping against. Whereas in the situ and the NRP, you can load the heart, you can come off, and you can see exactly what it looks like under a load. And so that's one of the major differences, I think, in those two that is probably not talked about a lot. Ex situ versus in situ, and these are starting to narrow the gap. It used to be distance. We were concerned about that 4-hour mark, and so if you had even if you can get, once the organ gets here, if everything's prepped up, the fastest guys here sew it in 30 to 45 minutes. That being said, you've got a distance of flight, you've got 2 ground transportations, and then you've got to get it sewn in. And so if you already have a 4-hour or 5-hour flight, you're already 5.5 plus 2 ground transports away. And so we've pushed upwards of almost 8 hours on cross clamp, not on cross clamp, on ischemic time. Timing of this. You're in a hospital to where you're having to utilize an OR that typically could be used for what I want to call a elective case. And so a lot of the timing is not conducive to having donation at all hospitals at normal business hours. And so sometimes at the middle of the night, the family consent, they also have to get to the hospital. They also want to be with their loved one most of the time, to be with the withdrawal state. And so that you have to take into consideration. Organ reconditioning, and then risk factors, and then just the general resources, what it takes to do this. Transmedics has now offered a full all-inclusive plan. And so that's very attractive for a lot of centers. From a resource standpoint, it's just call them up and they deliver the organ. And so that's a very, very attractive, option for a lot of centers. The one thing I will say that I think is overlooked is the predicting demise. And I had a colleague of mine joke that says that they're building this formula to try to predict demise on patients on DCDs, and so we can get better at predicting which patients we should go after. And
is it 40% right now that basically don't expire?
It's about 30% for us, and
30.
And in the beginning it was 10% because we were only going after more or less what I want to say certainties. but it's creeped to about 30, and I think it's because we have found that really there is not a predicting value. And what I was getting at, he writes off this long formula of different parameters of a patient, and then at the very end he also puts a multiplier of flipping a coin at the end. And so he gives this presentation on how you're going to predict demise. It's a couple slides of talking about NRP, and he's giving you all this informational data. And then at the end, it's still a coin flip, because we don't, it's a separation of church and state on the people who are taking care of the patient with comfort meds, and then the procurement team who stands, in a completely different room and has no interaction with that, and no interaction with the declaring physician or the declaring nurses either. And so, there is a complete separation, and I don't believe there's a predictive model that you can do, because you can't, there's no way you can take into account what the medications and what the dosages that the comfort meds are giving at. That's all independent. I think we would have to get into some palliative care discussion, and when protocols come out with that, I think we could have a better idea, but I don't see that coming along anytime soon, that there's going to be regiments on what you're supposed to give and when.
I've got a question, if I could throw
sure.
it out at you. It's just it's sort of an off the wall question. But, I'm considering this from a financial perspective. When you go to retrieve a heart and you've sent a plane, 10 people, whatever, all this equipment, and you leave with, whether it's heart or anything, I don't care what it is, and you leave with nothing, who burdens that expense?
Well, the burden of expense is on the institution that was trying to retrieve the organ. Many times, that's, we'll just say it's 30%. So 30% of the time we spend, we spend, whatever the dollar value is on 2 perfusionists. I'm just looking at it from perfusion only. The dollar value on 2 perfusionists, the disposable setup, the drug costs, and then you have to have your ground transportation. If you don't fly, it's just ground transportation there and back. But if you fly, then it's the chartered plane, ground transportation, there and back. Those things are not not cheap. And so
you're talking, you're already just in the flight. Let's say a short flight, there back. Let's just say you're going to go. It's an hour and a half flight, hour flight. I'll make it an hour.
Yeah.
You're just for what you just said, not including the cardiac surgeon and everything else. You're probably somewhere around 30,000.
Yeah, I mean, at least 20 for sure.
Yeah.
And so the flight costs are what they are. They range anywhere between, based on what kind of plane you're getting. But when you need a minimum of 5 people, that's what we take. I think the flight cost is anywhere between $4,000 and $7,500, $8,000 an hour, depending on, and that's also you have to weigh in how far you can travel.
And that's flight time only, or is that per hour of flight time, or what about staying at the airport waiting for you to come back?
Yeah, I don't know. I think that's flight time only.
Okay.
And so, but if we would have had, we went to Seattle the other day, had we had 20 or 30 more knot headwind, we would have had to stop to refuel.
Oh.
And so you don't take that into consideration. In 2 years ago, we didn't take that in consideration because we wouldn't go that far. But now even those things are even, luckily when we come back from the West Coast, we usually have a pretty significant tailwind. And so we're a little bit faster, but
that's where you want to save the time. That's the direction you want to be going.
Right.
Correct. And so all those things, you have to take into consideration. And, but as we are getting more and more patients, that they're either turned down at other centers, or they're very niche, HLA matching. You almost, if you have a patient that's has a low rate of, or a low probability of getting matched, regardless what the reflexes are on people, whether they're breathing over the vent, whatever their hemodynamic support is and their age, all those things come into consideration when you go to evaluate to go do a DCD. But as we are getting more and more patients that are a little more, what I want to call, the very on the outskirts of the spectrum of normal patients that we have to go and get a little more aggressive in going out there. And so that's why I think we've gone from 10% the first year we did this, or almost to 30%, because we are going after organs that are specifically tailored for these low probability patients that are, that they're tough to match. And so that becomes even more expensive if you look at it from a global picture of a silo in a single institution. And and that's where I think the collaborative nature, I think in 10 or 15 years, I think this will be so mainstream that there's no reason. There's going to be a predictive way to say this is how you do it. And I can see centers starting to pool resources and saying, hey, why don't you do the local recovery for us so we don't have to send an entire team across the country? You do it the same way we do it. And it's with anything else. You train people at an institution how the lead or the of cardiac surgery likes to train people, and then they go out into the world. They go get jobs elsewhere, and you can count on them because they saw the way you do it. They saw the way you like to do it. Hopefully they picked up on that's what they want to do, or they modify it a little bit to their own. But eventually, I see that we have, Vanderbilt fellows that go out in the field, and then if we do have an organ in a certain city or at a certain place, that those people can just procure for us and just send the organ back. And so that's where I think this goes in 10 to 15 years.
Wow.
Yeah, that sounds real nice if they can do it that way. A lot
Yeah.
less headache for everybody.
Yeah. And so just some demographics. These are these slides are a little bit old. These are for 20 to 2022. So we've expanded this. I didn't update these. We've done almost up to a 50-year-old on a donor. Time to incision, probably we've gone a lot more than that. We've bumped 2 hours from when they withdrew to incision. So we were very, we try to keep in kind of a tight scope. So in the first 2 years, the longest that we had waited from extubation to time to incision was 32 minutes. We're well over the 2 hour mark now. And then average time from incision to perfusion, I think this is generally probably the same. And you say that 1 to 4 minute. Well, 1 is when they're on ECMO. And when they pass, you literally just cut the lines and you hook back up to NRP. And so those are kind of outliers, but we're generally on within, I think the ECMO skews it a little bit to the left, but we're generally on between 3 and 5 minutes from incision to perfusion.
Wow, that's fast.
And then the recipient's characteristics. So this is probably the same range. We've transplanted a couple 70-year-olds, I believe. And then our Interscope score is about the same. We're seeing the same results across the board.
I'm not familiar with the inotrope score.
It's based on what I think is the number of inotropes and the amount of inotropes. So it's almost like an index.
Okay. Do you know the scoring for it? I can look it up.
I don't. Like I said, I don't know exactly what the formula is for it, but it has to do with the number of inotropes that you're on and the dosing of each. That it gives you what it does is what they're trying to do is they're trying to account for individual practices as who's running the ICU, and it's not necessarily within one institution. It's so you can compare other institutions, because maybe one institution wants to use dopamine versus dobutamine. And so you've got something that you can index across the board based on the inotrope score.
Gotcha. Thank you.
And you can see I've updated the data from this morning. And so you can see how our practice has changed a little bit. And, since 2023, I didn't include the ex vivo or we're also using the Sherpa cooler. And so we're changing a little bit, but we're adding, you can see NRP is definitely our preferred method that we're using. And like I said, it's about 40 to 45% of our total donors, regardless what year it was. But you can see the OCS is starting to decrease for us and NRP is expanding. And I think this is what I was talking about is you have to have multiple tool boxes to be able to go out and get these organs, and which is the best tool to utilize for not only the donor, the travel, but also the recipient. And
Sure.
so,
I mean, I think, there's going to be, it is going to be multifactorial, right? You're going to have to, you have to take into consideration, obviously, the first thing is going to be outcomes. You got to look at, okay, what are the outcomes versus using OCS versus NRP and static cold storage? Over what range of time frames, what distances, all of those factors. It really comes down to time. It's not, I don't care about the distance. It's time. Time is time. Whether you're doing it for distance, or you're doing it because you're having to walk. But nevertheless, you then have to concern yourself with the cost. What's the cost of all of this? So outcomes is first, cost is second, logistics, of course, is third, and then reproducibility is going to be in there too. And all of these things are really important. But I said yesterday, I think both tools are needed. You have to use the tools that are appropriate for whatever the circumstances are. So I don't think OCS will go away.
No, by no means.
But I think that its utilization is going to be more specific for certain things versus where NRP is going to be for other things.
Agreed. And ex vivo will be the same, and Paragonics and Organox, and there's a new technology that's coming out. I think the paper is going to be in the New England Journal of Medicine this next month. That we've come up with a new. It's called REUP. That's an acronym, and essentially it's using Del Nido and drug and blood cocktail to go in and do an in situ recovery without animating the heart.
Okay.
As you can see, that's the data that we've got. And then, in 2024, we did over 124,000 miles to retrieve, those 162 hearts.
Do you get frequent flyer miles for that?
Do not, unfortunately.
Oh no,
that's not good.
That's tragic.
No. And so, there are, everything we just talked about are the good things about NRP, or it expands the organ pool, gets more donors matched. But, there is a learning curve to it. Cannulating a flaccid aorta, cannulating using the right kind of cannula. This is one of our early NRPs. I think it was the first 5 that we did. We had aortic complications on 2 of the first 5. The good thing is, you don't ruin everybody's organ. You just walk away from your own, and they can do a rapid recovery flush. So that's where a time frame, I think, needs to be talked about on the front end and the timeout. How long do you have to actually get on NRP to where the other teams can say, okay, no, our organ's in jeopardy, we need to get on. And so there's always a good idea to have that kind of conversation before ends.
Yes, we should. You're right about that. And actually, the very first case I was ever involved in was a case like that. We went on NRP, and there was literally no venous return coming back. It just was all getting pumped in, and it was recognized that obviously this is in the aorta, opened the aorta up, and found a big dissection. and just immediately went to rapid recovery and took the organs and the liver and the kidneys, and they jammed out of there. So you're right; those organs didn't get wasted. The heart didn't make it, but the rest of them did.
Yep. And so, so you can see that in this is the one slide that we put in here for, for the abdominal organs and livers in a controlled donation, have a higher incidence of non-function and poor ischemic cholangiopathy than in NRP. NRP, clearly is better for DCD livers than non-DCD livers. So, it's starting to become the standard of care across the country. And this is one of the earliest studies done that talks about that. And so, just wanted, that it is here to stay, in for sure in the abdominal space, and Vanderbilt being a little bit of a conservative organization. We've started in September of this last year to really pick up the pace for the abdominal DCDs. And if you want to grow a DCD program, this is what it looks like. You ride in a lot of tight spaces, only get to air and ground, and you have to have an institutional commitment of more beds, more staff, more operating rooms, or at least operating rooms running at non-traditional hours, and a robust ICU team, because we found that as soon as we started this, it kind of exploded. It can take you to down a quick path quickly, and you have to be prepared from an infrastructure standpoint to be able to drink from the fire hose, as I like to put it. And in conclusion, more or less, DCD, you can simplify it. I think that's the thing to do, is do it the same way every time and make one change at a time. So we changed the aortic cannula was first when we made 27 different changes to our process of NRP within the first 18 months. Now, we haven't made any changes probably in the last 2 years from an NRP standpoint. Now, we've modified some other things to try to go after some more organs that NRP wasn't allowed in some hospitals, but they would let you bring in a pump to give blood to a non-beating to more or less preserve the heart, but don't let it beat. So that's where the re-up came in. And so we're working on different avenues once again to put a different tool in your tool belt to not only for the patient, not only for the donor, not only for the time of travel, but also for the institutional guidelines where you're going to try to procure an organ. DCD definitely improves outcomes when it comes to abdominal organs, and it shows in the short term for cardiac that we have really better results over the first 2 years, and then for sure it increases the potential organs for transplant. So 2,000 DCDs done last year, I believe, across the country. There's 2,000 people that die every year on the liver transplant list. And so every single DCD patient, I'm sorry, there was 2,000 DCD patients, not 2,000 NRPs, 2,000 DCD donors last year. So if every single one of those DCD donors could have gotten their liver placed, the list would almost be exhausted. Now, the good thing about it is as the list gets lower, you get earlier adoptance of people that maybe have lower MELD scores. So you don't have to get sick enough to get on the list. You can, it's the whole idea is why do we want to wait for someone to have multi-organ failure if we can just address the singular problem? And so I think that's where it goes from here, is that we will get healthier and healthier people on the list and have probably, better outcomes. If you have healthier people on the list when they do get their transplant, they're probably healthier coming out of it. And then, I think there's a lot to be learned about ex situ versus in situ. I don't think that they are mutually exclusive. I think they work hand in glove in this environment. As I said, I think you have to have all the tools in the tool belt, and you pick which tool is most appropriate for that particular setting and patient. I think higher volume programs need not only both, but they need multiple modalities of both. And things are evolving with iterations that are coming around that, you're going to have multiple ex situ machines. You're going to have multiple in situ therapies. And I just think it's a very exciting time to be in the transplant world and the organ procurement world. And because I think this is just the beginning of where I hope that we end where everybody's collaborative. Like I said, I think it would save a lot of efficiency as far as time and travel if people could collaborate across the country from center to center and say, hey, we've got our donor here, you're on top of the list, we can do this for you and send it. That's where I wish that this would get to towards a true organ donation, organ recovery,
nice.
organ sharing network.
That would be incredible.
That would be
incredible if that could happen. Well, that was certainly excellent, informative conversation, and really appreciated it. I do recognize, however, and that you have some limitations because you, again, are speaking on behalf of Vanderbilt University. So I'm going to be very careful. But if I ask anything that you're like,
Sure.
well, I really can't address that, please don't hesitate to just say that to me directly. I'm going to bring up a slide, and I'm going to ask you to please explain to us how exactly this circuit works. It seems fairly intuitive to me, but there's parts of it that I have some questions about that I don't understand. Mm-hmm. And this is a Transmedic slide that I had. It's not a slide, it's a PDF that I was able to get downloaded. And go ahead and bring up that slide if you can. And if you look right here, it's you see the circulation on the OCS. Can you please go over that?
That would be nice.
Oh, did
Sure.
we lose Matt? Oh, where'd he go? I can't see him.
Am I there?
Oh, okay. Sorry. All right. No, that's my fault. All right, go ahead. We can only hear you. We can't see you.
Sure. And so we'll just start with the basin. We'll call the reservoir. And so there's blood that goes out of the right atrium. So the right atrium there has a cannula, and
The right atrium. Well,
the
this says PA.
yeah,
don't-
the PA. So I'm sorry, the right atrium. The right atrium is vented to where if there's any blood that is actually that the PA can't handle, there's a pop off, and so it drains out of into the reservoir. The PA cannula, it gets directly hooked up, and so that is also where you measure your venous sample, and that's where you compare your arterial sample to your venous sample to see if lactate is being consumed or lactate is being made. And so those are the two samples that you pull from. You pull from your aorta, and then you pull from your PA source, and that's where you get the more or less the delta in between. Mm-hmm. As the blood comes down.
And does that CF SVO2 probes? Is that is that coronary flow? What is the CF?
Yes, and so that's right. And so it measures coronary flow of what is going on, and so you want to make sure that there's no leaks to the whole circuit. And so, like I said, if there's any shed blood going on, it does get collected in the reservoir, but they tend not to want to have any leaks because they want a whole. That's what their calculation is based on, right? That it's a whatever QP to QV, right?
So okay, so let me make sure I get this. So basically, any blood that is pumped by this pulsatile pump through the oxygenator and then through the warmer down into the aorta is the only place for it to go is the coronary arteries. Or
that's correct.
Or I guess there must be a Y where it flows out and over into the reservoir, whatever doesn't go down the coronaries.
Correct.
And then whatever goes in the coronaries ends in the right atrium to the RV and then out the PA. So do they calculate basically just the PA outflow and assume that that has to all have come from the pulmonary, the coronary circulation?
That's correct. And then so with that second arrow that's coming out where the aorta is, there's a vent that gets put in And as the blood gets pumped, so let's say 1.1 flow, that's what the pump will say. And then you'll have coronary flow of, let's say, 850.
Right.
Well, the difference is there's 250 between that. Well, the 250 comes from what are the oxygenated blood that's coming out of that PA, or out of, out of the left atrial vent.
Gotcha.
And so that's vented to the reservoir, and that gets collected, gets put back in. So the numbers that they're looking at what the direct fluid is getting pumped down the aorta. That's your flow, your pump flow. What they're measuring is from the PA is exactly right, Joe. It's exactly the coronary flow. The difference is what that's what's coming out from the LV or the LA vent. And then your two lactate samples is whether you're consuming or whether you're producing lactate. And that's essentially the nut, in a nutshell, what that is.
Okay, so if we can go from there, you don't mind, and I've got another image I can show you too that I think is going to be important. But why is the pump pulsatile, number one, and does it need to be? I guess my question number two is, why is the gas exchanger oxygenator? And why do they use square items for oxygenators beyond me? But nevertheless, they're going to a chiller, but then you have a warmer. Like I'm trying to wrap myself, because these slides really don't explain that to me, and I don't understand. I can't really understand the system.
Well, so the gas exchange, it's a quadrox oxygenator, so that's why it's square. And it has the heat exchanger. It's the same way, and the heat exchanger is only, well, I should say that the chiller, as they're calling it here, is really only when you're going to be ready to take the heart off. Is that you actually make the blood cold that you're giving.
Okay.
And so, but the heat exchanger is just for ambient temperature, and they try to keep it at 34 degrees. That's the goal. And the reason that they want pulsatile blood flow is because this, unlike the other, like the ex vivo or the other devices, this is a beating heart product, and so they want to use counterpulse. They want to use counterpulsity, just like a balloon pump. They want to be able in diastole and systole to feed that. So that's why it's pulsatile.
So is it timed to the cardiac?
It can be timed. It can be timed. You can put it in where they call sync mode, and so you can. They don't necessarily. You don't start off in sync mode, and you can use sync mode to optimize things. And I haven't done it in a while, so I can just tell you in my experience with sync mode, we use sync mode as a last resort if for some reason we couldn't get the parameters to where we were consuming lactate. We tried flow, we tried dilatory agents, because there's medicines that you dial up and down with this too. And so you've tried all your things, and then if you still couldn't get a diminishing lactate, you would try pulsatile, or you would try sync mode, they call it.
So
and it would
So let me ask you this, if I can, if you could just entertain me momentarily. Would it not? I mean, I understand that it's pulsatile because the heart's beating, and I've seen it beating in the box. We've all seen those videos. It's really exciting to see. But if it isn't actually synced, and all you're doing is just pulsing blood up there, if it was timed for when it pulsed at the exact moment the heart went into diastole, then that would, to me, make a lot of sense. But if you're not going to do that, wouldn't it just make sense to set your perfusion pressure, your coronary perfusion pressure, where you think it's going to be optimal, and leave your flow there?
Yeah, well, the difference is because in this model, even though the heart is beating, it's not ejecting, and so the aortic valve is always closed.
Sure, and but then why pulse?
Well, because just a natural contraction of the muscle on your arteries, you actually get a more you can get a more spastic, a closed, the arteries get compressed and relaxed during the systole and diastole. And so while it's not exactly the science when it comes to the pulsatile pump. The pump is pulsatile at all times. That's how it moves the blood. But unless you put it in sync mode, it is not timing with the EKG. And so I think that's the difference, is that it doesn't really need, and because your heart isn't necessarily full. And so you can imagine a full LV squeezing, you've got blood inside, you've got the wall muscle squeezing,
Sure.
but there's no real LV pressure.
Right.
And so the internal compression on the muscle doesn't necessarily act in the same motion as it would on a normal heart. And so I don't think that you need pulsatility on every single case. It's more or less those ones that you really can't.
I
get
got
right.
it now. So it's just designed to pulse, but you generally don't unless it's necessary.
That's correct.
Got it. Okay, so here I see the diagram showing how they attach the main input, main arterial return to the aorta with, I guess, these pledgeted stay sutures, and then they use a tie band. Is that done? Like, is that at the top end of the sinotubular junction, or where exactly is that cut made?
It's pretty. You get a lot of aorta with that. So because they don't really ever take that, they actually cut that whole piece off, and so there's a lot more aorta there than what it seems that the picture is showing. It's because they usually just cut below the tie band and they leave that cuff on the device that they throw away. And so it's a lot higher than what you think it is.
So is it like right before the innominate comes off?
Yes,
or?
yes,
Okay.
almost the innominate. Yep.
So it's definitely distal to the STJ.
It definitely distal. Yep.
Okay, very good. Thank you so much. So that fella I told you about that was asking that question, he's back online. Super nice guy. He is a perfusion. In his third year of perfusion training, currently in India, and I think they're using OCS there. And I think after initiation of OCS, we try maintaining 1 liter of flow and aortic pressure to be about 70 to 80. So he has experience doing this as a third-year student in India. And he was the one who asked the question about the solutions. I told him that you answered it already, but since he's now online with us, you want to go over that again, the UW solution versus the custodial?
Yeah, I don't
HTK.
know much about I just know that there's 3 different preservation solutions. There's UW, there's the custodial, which is HTK, and then there's the Del Nido solution, and that's what we use here at Vanderbilt. I do know that the custodial versus the Del Nido, that's the kind of the study that we reference. There's not a lot of difference in the outcomes of those two, but the immediate kinase markers are lower in the Del Nido than the custodial. However, it seems as though the custodial, the length of stay on the patient is a little bit shorter, and so you don't know if that's due to the edema or what happens on the intracellular or even the macro scale, but we feel that the kinase markers make up a significant portion of the reason that why we do that. And Dr. Shaw, being a Duke guy and a Hopkins guy, that's the route. The Del Nido route is what he took.
Now, do you use Del Nido or modified? Do you add blood to it?
So we use Del Nido in our DCD recoveries, whether it be NRP or OCS. We use a modified on this re-up.
Okay.
And so that paper will be out later this month, like I said, in the New England Journal of Medicine.
And you guys have, outcomes that are just incredible. So, and outcomes that are incredible, and volume that is incredible. So you definitely have the experience.
Yeah, and I think those come hand in hand. I think you have to have the volume to be able to push the envelope, because if you don't have the volumes and you have some marginal outcomes based on people that were turned down in a couple different places. If you didn't have the volume to do that, your results wouldn't necessarily be as good as what the risk score of going into the surgery. You have to account for that as well. I think you have to have, that's why you do why high risk centers do high risk things.
Gotcha. Yeah, that's true. Okay, so let me say, so we have an ischemic time here in the States at each hospital. It could be between 90 and 120 minutes, and that's from time of extubation or withdrawal until you have to walk away. We're not going to do the procedure, and it varies from 90 to 120 minutes.
Some centers actually only give you 60 minutes.
60. Okay. So
Yep.
where does that number? So who is deciding that number, and what is it predicated on?
That number is generally decided by the hospital that's there, because everybody's utilizing their resource of a booked time. They're utilizing their own scrub nurses. They're usually utilizing their own circulating nurses, and they're using sometimes their own RT or someone there to withdraw or reintubate if you're taking lungs. And so it's generally dictated by the donor hospital rules and regulations.
Does the donor hospital, do they get paid? Do they get OR pay?
They do get compensated by the OPO, yes, in some form or fashion. I don't know how that works.
So, wow. Okay. Now the standoff time. This is going to be probably the one that's really going to get my attention. Okay. I think everybody's attention.
Yeah.
So they die and we rush in there. There's that 5-minute wait. Everybody rushes in. If they're not already prep, rapid prep, drape, cut, incise, and 1 to 4 minutes, depending on whether they're on ECMO or not. So 4 minutes, no, they're not on ECMO. You guys are getting cannulated and getting on because it's all about time. But yet in Italy, they don't touch the patient for 20 minutes.
20 minutes. Yep.
So my question to you is, how are their outcomes compared? How does that 20 minutes, how has that demonstrated either no or a negative effect on the outcomes of these organs after transplant?
I don't know. I don't know that we have a comparative of what U.S. results are to Italy's results, but what I will say is that their results allowed us to, in the first 3 years where we didn't want to take more than 32 minutes of agonal, and that's kind of what the Transmedics protocol started, no more than 30. But when you look at, you've got a 5-minute standoff or you've got a 20-minute standoff, and it takes you this long to cannulate. The Italy experience, they're getting fantastic results as well of the organs that they recover and the organs that they actually accept.
Gotcha.
And so I think there's a difference between, working with a time frame that says, oh, well, we have to get on. No, there's outcomes out there that you're waiting, and if you're doing the proper NRP, if you're turning around the organ at the level that you have set out to do, good global end organ perfusion and capillary perfusion, and you can do it long enough to where your lactate is coming down and you're getting good recovery of the organs, you're replenishing the ATP, the mitochondria at the mitochondrial level, and you're able to do all that without the added insult of reperfusion injury and using high oxygen demands, and that's where this next level of NRP is going to go. Should we just use 100% FiO2 or FiO2, however you want to look at it, or should we be tailoring it? That's where I think in the next 10 to 15 years, the studies are going to be that say, hey, giving 100% oxygen is not best when you're going on with the lung, or, if you're trying to recover the lungs. And there's already data that's out there that anecdotal or, white paper data that people are already starting to tweak and modify the practice to be able to say, okay, if we're going after a heart, it may not matter if we give 100%. But if we're recovering lungs, it does.
Yes.
And so those talks are already starting to brew up, in back channels and, at small tables at these venues, at the meetings. And so I think that's where it actually will evolve.
Very good. Okay. Now, I guess my point to that was when we see some of these issues happen with newer surgeons that are cannulating in a hurry.
Yep.
I could just see the they're not used to it. And so, and yes, you're right, the flaccid aorta is problematic. But it would seem to me that if Italy is having these kinds of results, it would be prudent to recommend to our cannulating surgeons, hey, you take the extra 2 minutes and do this a little more slowly, a little more accurately, less problems. That 2 minutes is not going to hurt us. That's my belief. But
No,
I
agree. You're right on that.
You do.
No,
Okay.
I would agree with that. I think NRP cannulation is just like, CVP cannulation, or it's probably more like ECMO cannulation.
Yeah,
if you have bad cannulation during ECMO, you're going to continue to have a bad cannulation for the rest of that run.
Yes.
NRP, if you have a bad cannulation, you're going to have a bad cannulation for the rest of that run. And we all know that bad cannulation, yes, can you get through it? Yes, but it is not optimal. And in reality, sometimes you can't get through it.
Mm-hmm.
And so, that's the real point.
I've got two more. I know you have to go, but I've got two more questions if you can answer them possibly.
Yeah.
One, perfusionist versus specialists. I understand that CMS recently has come out and said, okay, no more NRP by non-perfusion people. It's going to either be perfusionist, whether certified and or licensed or both. Can you elaborate a little bit on that, and where is that heading? Because I see this service line becoming too big for perfusion alone at some point.
Yeah, and I think that's going to be a problem. But I will say that I don't think, in my experience, we have used 100% open reservoir. I know there are some centers that are toying with the idea of a closed reservoir, and I think you have to lend yourself to the specialty that you're in. Perfusionists are used to open reservoirs and closed reservoirs. I think specialists are used to closed reservoirs or closed circuits only, whether it has a bag or whatever it is, but it's closed system. And so,
but that's very impractical for NRP.
Well, it is unless unless they're venting, unless they're putting in multiple vents. And so I just recently have heard about where they're putting multiple cannulas in to keep the heart decompressed, and they're even bloodletting off to a bag to make sure that the volume is decreased, and that you've just got enough just to keep the more or less the pump going without distending the heart. And so there's some other ideas that are coming out that you could use a closed circuit and bloodlet off of the bag to make sure that your reservoir isn't your heart. The reservoir is truly the bag, but you could lower the total circulating volume to make sure that your heart, which is at a higher level, would drain appropriately to not be distended. And so there's a lot of thought and a lot of ideas that are coming around this, and I think it's very stimulating, if nothing else, to have the discussions about what could we do to make this easier, what could we do to have more people be able to do this because it's an easier process. And I'm not opposed to that, because to your point, if we had to do 2,000 more NRP cases a year, that's 20 or 30 more perfusionists that would be doing 100 or 75 to 100 a year out there. That's not an insignificant that's not an insignificant increase when it comes to the number of people that we have in the industry.
Agreed 100%. Last question. Why do some places demand that only OCS can be used, or only if it's NRP?
I think it has to do with the beating heart. I think it has to do with a lot of denominational institutions that reanimation is considered beating heart. And so when you do NRP, whether it's for retrieving the heart or not, if you do TA NRP, unless you exclude out the coronary arteries somehow, whether you clip them or you put a clamp on the outflow of the heart, but proximal to your your thoracic cannula, arterial cannula, you're going to get reanimation of the heart. And in some hospitals, their medical boards, they feel that that's reanimation, and that that is life coming back. So I think OCS, because you wait for the heart to to stop, you cut the heart out, you put it on the back table, it's not reanimating in situ. That is the loophole and it's not a loophole, it's actuality. The heart doesn't beat until it's outside the body cavity. And so that's when I think there's some places that they only let transmedics in. They don't let NRP. And that's the other reason why we have tried to develop this re-up thing, because it takes a lot of the advantages of NRP when it comes to only the heart, but it doesn't allow the heart to reperfuse, to beat. So the heart doesn't beat in situ. And so, but it has the downside of things that you don't get to test the heart to see what it functionally looks like.
Yeah.
You can't load it because the aortic valve is never going to open until you're
correct.
Until you put it in
until
somebody.
You reanimate again. Yep.
I mean, that's going to be really tough to do.
Yeah, but what it does do, it provides all the nutrients and all the ATP generative properties back into the myocytes over a short period, because we're giving this solution over 10 to 12 minutes. And so, NRP, we're on anywhere between 45 minutes and an hour, usually for hearts. But that's going to the whole body, right? And you're washing out the entire metabolites. This, you're just doing it just to the heart itself for 10 to 12 minutes. So it's almost like an extended cardioplegia flush. It's washing out the metabolites. It's, making the heart stay quiet. But on the same token, it's also rejuvenating the mitochondrial components of the myocytes. And so that's kind of, and it also, fits the criteria that the heart is not reanimating, and we're not using, the transmedics device, which, as you spoke about, is pretty costly.
But why do they do that with livers? Like, I've been places where I've gone on cases, I'm standing there, the patient dies within 30 minutes, transmedics is taking the liver, and they're going right down the street, down the street.
Yeah.
And they will walk away, and then we'll wait, and the patient will die in 38 minutes, and we'll NRP it, and then they'll take that liver, send it to the secondary location, and they'll implant it, they'll implant it, and I'll call 3 or 4 days later, patient's doing great.
I think there's two reasons, and we're starting to see this with lungs. There is so much work that's being done. You can use transmedics as a holdover if you're doing back-to-back organs. So if you've already got a team committed and you're in the middle of a transplant, if you cross clamp, well, you're on the clock and you have to get that thing in. If you put it on an OCS device, you don't really have you don't have a shot clock, if you will. You can wait till you get your first organ transplant done, let the team recover a little bit, and then put the next one in. The center in Cincinnati, they routinely have 2 or 3 livers, going at the same time. And so they use that device as a bridge to be able to say, okay, this organ needs to go now, this organ needs to go next. We can put this one on a transmedic, and we can use that one as our third case of the day. And so you're using it as a bridge for to a time that is most suitable.
Okay, throw up my slides real quick. So you're telling me that you flew from Las Vegas, or no, actually from Seattle, so farther. So yesterday I told the audience that trip from Las Vegas to Nashville was going to be too tight of a window for just static cold storage, NRP, and then explant cold static storage, and then to Nashville. But you're telling me you would have no problem with that whatsoever.
We've gone all the way to Alaska.
Holy
We were
mackerel.
talking about Alaska not being a place, remember?
Dude. Well, that kind of hurts this. I'm gonna bring it up here somewhere. I don't know where it is. Let me see if I can find that slide. It's back this way. It won't take me long. So what you're saying is, it's probably at the very beginning. Watch. Yeah, of course. So this.
If I could,
This doesn't
This
apply.
piece here, this this section that you see in the middle in red, that's really not as the one on the top really isn't as ugly as it seems.
it is not, and I'm going to show you. I'm going to share you. I'm going to share a slide with you,
Okay,
if I can. Let's see here.
just share your screen and it'll come.
Yeah,
right
I'm going
back
to share
up.
you. I'm going to share the screen here.
And then David over there does his magic.
Yeah. What is the longest ischemic time you've experienced where
Can-
the organ was still viable?
Are you
and
seeing my
accepted?
screen?
Oh, I see your screen. Yes. Probably things there we might not want to see, but there it is.
No, that's okay.
Yeah,
We got
there
you.
it is.
So 5,700 nautical miles, and
Wow.
it was a cold storage, and we put it in the cooler. That cooler right there.
750.
No, 5,700 nautical miles.
5,700.
Yeah. It's Alaska.
Yeah.
Canada's very big.
Yeah.
5,700. And the patient,
So-
was it heart, lungs, liver, kidneys,
Heart.
everything?
Heart.
Heart.
Yep,
And,
Oh,
it,
wow.
and it went in.
Organ
And they
was
took
preserved
it,
for
better
10
yet?
Yeah, 10 hours and 22 minutes before.
How did the patient
was the ischemic
Oh, my
time.
God.
how'd the patient do?
Fine.
Just,
10 hours, 22 minutes.
That's
Joe.
amazing.
That's amazing.
well, and this was after it was NRP'd.
Oh, my God.
So-
That's correct.
So let me ask you a straightforward question. When it comes to, I'm just going to focus on the big three: heart, liver, kidneys. I'm not going to include the lungs in this conversation for the sake of I don't know enough about it. I'm going to leave it out. Would you say that NRP gets these organs in a place that would even be better than DBD as far as their condition is concerned in the reanimation phase because of all of the cocktail of things that are given and then the flow and the measurements and so forth? Do you think those organs are really viable, a bit more viable than if you were to just do DBD, just rapid
Well, I don't-
recovery DBD?
I don't feel comfortable saying, this. What I will say, I don't feel comfortable making a comment on this. What I will say is that there is no doubt that there is a hormonal contribution to end organ function, not only from an organ standpoint, but at the cellular level. We know that hormones matter.
Oh, absolutely.
And so when you are brain dead, you are no longer secreting,
We talked
hormones.
about that organ
your head.
crosstalk.
We did.
Organ
And-
crosstalk.
Yep.
And so the whole idea
Your hypothalamus,
is that,
it's very
and
important.
the reason I would say that we see some of this is that unfortunately with some of the donation when it has to do with DCD, the patients that have some sort of asphyxia or some sort of hanging or some sort of isolation of the cerebral circulation to the rest of the body, those organs in DCD act very much like DBD donors. And it isolates them to those asphyxiation or head or some sort of neck injury that doesn't allow for blood to flow at a certain, for a certain time frame. And so those organs act like DBD donors. And so it's anecdotal, but that's once again, that's going to be the next level of testing Why are they, they've already shown that there's livers that do better and there's heart that do better in the short term, 1 year, 2 year survival. But why is that? We don't know. But I have to think it has to do something with the hormonal contribution of end organ, function. And so that's what I would say. I feel comfortable saying.
That'd be very interesting. Our friend from Paris says that they did, and I'm afraid I only know the name is
No, they did. I know what they're going to talk about. They did. They went to the Caribbean and picked up an organ.
12-hour flight with a heart.
Yep.
Did they do NRP? Yep. Did you do NRP first? Is what I want to know.
Yeah.
What'd they say? Oh, they haven't answered yet. So, if you could tell us whether or not you did that with NRP first, would really be appreciated. He was not there, okay? But somebody was there. Did they do NRP? Do you know? Find out for us, and we want that answer because we're going to bring it to our audience the next time that we have a chance to visit with them. Okay?
They did it. He said
they did. They did?
Yeah.
They did that.
Yeah.
Bingo. I knew it. Thank you. Matt, I know I've kept you way longer than you were expecting, and all I can tell you is I owe you so much, and I can't thank you enough for everything. I wish you guys the best out in Vandy, and I need to come back out and see you again pretty soon.
Yeah.
Sounds good. Thanks for having me on, Joe.
Thank you. This is fantastic. Be safe, sir. Bye-bye.
Bye,
Bye-bye.
Matt.
Dude, he's a rock star.
Dude, yeah.
He's actually a rock star.
Like you said, he's the foremost expert,
He's
right?
he
knows his stuff.
He's my hero, bro. That guy knows some shit. That's all I can tell you. I wish I knew as much as he did. But he talked about hormones and the hormone issue.
And that's a big deal. I mean,
yeah, I want to bring that up to you actually. But do you know, in that circumstance, do you know how to make a hormone?
What do you mean? Do I know?
Do you know how to make a hormone?
Hormone's just a signaling.
No, you just don't pay her.
Oh my God!
Okay.
I didn't know. I thought you were being serious.
We'll see you tomorrow. Same. I don't know what time tomorrow.
Same time. 11.
Same time.
Yeah, same time.
And we're gonna go into the raging inferno. We're gonna go in there and we're gonna talk about all kinds of stuff related to NRP.
Goat ready.
We're gonna have the goat ready, and we're gonna talk about let's make that goat go off here.
Yeah. Of course.
There.
I'm gonna use the goat on you tomorrow. Watch.
Okay, and we're gonna have fun talking about a lot of these things from just a basic, fundamental, operational, controversial perspective. Talk about all these concepts we talked about, maybe in a little more detail. Some of it may be just conjecture and trying to understand it, but some of it maybe you guys can share some information of your experiences. I would love it. Thank you very much. Thank you for that
I mean, these
compliment.
guys blew my mind, Joe, today.
If you could possibly get anybody that was involved in that case to maybe just type in or call in or whatever tomorrow, we would absolutely love it. Somebody from your institution that may have been involved in that. We would be so appreciative if you could do that.
Absolutely.
But we'll be here tomorrow. So if you want to do it, okay? Or anybody else wants to bring it, bring it. Akash, it was a pleasure seeing you again. Thank you so much.
It was.
We had SK here today. I haven't seen SK in such a long time. And SK, we were, I don't know what I was talking about here. I think I was talking about at the time ECMO, but it's appropriate for anything, right? You're just measuring things. So a lot of what's in the ECMO section is already in the perfusion section and vice versa.
Yeah.
And the app has a lot of redundancy throughout it, but I don't want people to have to try to remember, well, that formula is in this section. So there's some sections, formulas
better
that
to
are
have
just
it in
going to
two
be
places
well,
than none.
Yeah, it's going to be appropriate across the board for a whole variety of things. But anyway, with that said, we will see you tomorrow. I think we're ending maybe 7 minutes early. Hopefully the board won't punish me for it. But thank you all for being here, and we'll talk to you later. Peace.
Yep. Peace.